we are very privileged to have Dr. Ivan Stewart. Dr. Stewart is the Executive Director of Bethany Kids, which I think most of us here are familiar with. Bethany Kids is located in Kenya. It's affiliated with Kajabi Hospital, and this is a beautiful Christian outreach that is dedicated to the holistic care of children with various deformities and surgical conditions and disabilities. Dr. Stewart has been in Kenya for a number of years participating in palliative care. I'm an internist myself, but I do have about a year and a half worth of experience in palliative care and hospice, and I know firsthand the need is tremendous, and certainly there's a tremendous need as well in developing countries such as Kenya. So a lot of us, this is a new, I'd say really the newest subspecialty of medicine. But it's growing quickly, and if you're not familiar with it, you'll hear a lot more about it in the future. But Dr. Stewart's going to let us know about his role in palliative care this morning, so we appreciate you coming.
Well, thanks very much. It's a privilege to be here with you all and with those of you who are elsewhere. I haven't done a lot of palliative care in Kenya. I've done some, but mostly in teaching rather than actual practice. And because I'm usually very busy with my other hat when I'm there, but and I feel a little bit awkward in what used to be called a tropical medicine forum, talking about something. I also feel guilty because as I look at the first slide, it says palliative medicine in the third world. Well, palliative medicine is in the real world because every one of us are going to die, and therefore it is very real. So, and so I just wanted to move on to the objectives of this little chat today. To really learn about palliative care, we provide a 4-day training course for family doctors in Kingston, Ontario. I'm one of the directors of that program. And we have trouble getting into 4 days the basics of palliative care. And so in 1 hour, I'm not going to be able to really not even scrape the surface of knowledge in terms of that. But I thought what I would do is talk just briefly about why Christians need to be interested in palliative care, the euthanasia debate and its complications and its implications for us, although that will be basically in passing as to why we should be involved, and a few of the problems that cause obstructions to providing adequate palliative care in the third world, and just end with something that is common to both first world, second world, third world, and every world, and that is the obstruction to providing adequate palliative care because physicians are afraid of using opioids. And those fears are grounded in myth, and I don't like to say ignorance, but really that's what it is about these drugs and really the benefits of them, the risks of them, and so on. So I'm going to touch on a couple of those things just to whet your appetite for more. And if you want to learn some more, you'd always be welcome to come to Kingston, Ontario, and take one of our courses, or I can communicate with you and advise you of other places where there are good courses in terms of CME for palliative care. So those are the objectives, and I want to declare one conflict of interest. I only have one because I used to speak occasionally for drug companies, and when I said what I had to say, they never asked me back. So for that, I'm not really grateful. But the conflict of interest that I really have is that I came here to share with people at Samaritans First about Bethany Kids, and you can't see the slides that I have up here, but if you want to know anything more about us, just go to BethanyKids.org. Lance told me I was quite free to do a mini commercial here for Bethany Kids, so that's the reason why I'm in Boone. I just start by saying, the people that influence in our lives. When we look back and think of people who have had a tremendous influence on us, people that were, I've used the word heroes, people of influence, but I thought back to the word hero, and I always like to look up definitions because I forget what the true meaning of words are. And heroes were heroes of ancient Greece, and they were really demigods. And the interesting thing is, when I thought about that, our heroes today, even amongst Christians in North America, are often people who very easily can become demigods in their lives because they involve sports, they involve things that really are relevant, and people very quickly replace Jesus as the center of our lives. But I want to just mention in passing, because it's one of the reasons why I'm here, a couple of people who have influenced me. And the first one was a hero from my young days. That was C.T. Studd. And many of you, of course, will be familiar with this English missionary from the 19th, 20th century with missions to China, India, and Africa. And he said this: "I want to live within the sound of church or chapel bell. I want to run a rescue shop within a yard of hell." And as I started to get involved with palliative care, I realized that there is nowhere more applicable that quotation can be put than people who are going to die today.
That's very good.
In 1982, I saw a patient in general practice with malignant melanoma in her foot, and I was really disturbed at the problem of pain management and the inadequate care which she received at the hospital. Because when I was my last year of medical school, a lady came to speak to us who's one of my other heroes. Her name's Dame Cicely Saunders, and she is the woman who founded the modern palliative care unit. She was a nurse and a social worker. She saw people dying in agony, and doctors walking away from bedsides, washing their hands and saying, "There's nothing else we can do." And she decided, after chatting to someone, that I'm going to find out how to do something. And she developed modern palliative care. Although when you look back, and I'm not going to give you all the history of it, but in the 15th century, hospices were places that people could go to die, usually run by religious orders. Now, Dame Cicely Saunders was a very special lady because she also was a follower of Jesus. And it was partly that drove her into this new specialty of palliative medicine. And she just didn't do it. She developed at St. Christopher's Hospice a worldwide known academic palliative care setting that really was interested in not just treating but also researching and advancing knowledge as to how to treat people who were dying. And someone once said, at a time when many people were starting to embrace euthanasia, Dame Cicely Saunders had a different viewpoint, and her vision led to a model that has changed the face of dying across the world. There are currently 3,200 hospices in the U.S. alone and 8,000 hospices in 100 countries around the world. You know, one of the things about palliative care that's sort of essential is the business of having compassion. And you know, it was a tremendous feature of the mission of Jesus. And in Matthew 9:36, it says this: when Jesus landed and saw a large crowd, he had compassion on them and healed their sick. Actually, if you go to Matthew 15, you'll find a little verse that's part of the basis for Bethany Kids, but I'll pass on that. But I did want to get a second mention. So, and so one of the three of the questions I have for us that are associated with medicine in other countries and practicing medicine in those environments. And the questions are these: can one be against euthanasia and do nothing about the suffering of those who are dying? That's a question that you have to answer for yourself. And it's not that all of us are called to be palliative care doctors. Don't get me wrong, I don't believe that. But all of us as physicians and nurses are involved in people who are dying. And we should know either how to manage them or who to refer to in order to make sure that they get adequate care. Because part of the drive for euthanasia comes from that lack. And the other thing is, ignorance is no excuse in this day and age for inadequate symptom management. The web is absolutely full of information and resources, and we can give you some of those resources at the end. And lack of resources, not an excuse to do nothing. It is, for Christians, a call to action. Just this last few weeks, there was a lecture given in Kingston, Ontario, and by a guy called Shuklink. And Shuklink is the chair of a Royal Society Commission on patient-assisted suicide. And here's what he had to say back in 2011 in the Globe and Mail, which is our probably foremost newspaper. He said, his interview, he gives the strong message that we Ulsters, and I'm in that group, are simply getting too expensive. Depressed people who can't respond to treatment should be able to get patient-assisted suicide, and palliative or physician-assisted suicide, and palliative care is so unavailable in Canada that assisted death is needed, as it is for the demented who no longer are considered competent to say they want it. And this is the objective of the chair of society that's supposed to be looking at the issue. Now, how you can, in a modern advanced society, have the chair of a commission who's so biased, beyond me. But anyway, I also just want to mention that part of the drive for euthanasia, a huge part of it comes from people who have Lou Gehrig's disease or myotrophic lateral sclerosis. And for them, the tremendous fear is the fear of dying with being short of breath and choking to death. So how do we deal with that? Well, we can work politically, which may change nothing, or we can try and do something about how people with Lou Gehrig's disease die. And that is, how do you manage the symptoms of dyspnea, which is every bit as important as the management of pain in the palliative care spectrum. And so in Kingston, we have a multidisciplinary clinic for Lou Gehrig's disease. And at that clinic for the last 2 years, I've been involved in providing really advice to people who have been diagnosed initially with ALS, and helping people with decision-making about what they want done at the end, such as whether they want ventilators and so on. So, I thought that seeing I'm at Samaritans purse, I should at least show this beautiful picture, which you can't see, unfortunately, by Conti, an Italian artist, on the Good Samaritan, and who was someone who decided to suffer with rather than to pass by on the other side. Working in palliative care, Jeff Stevenson from the UK wrote in Nucleus in 2004, said this: working in palliative care can be challenging and demanding. People die only once, and as carers, we only get one chance to get it right. But it's almost tremendously rewarding and full of opportunity. Christians have a huge amount to contribute. And you know, one of the sad things is that palliative care, which basically started by Christians, developed by Christians, at the forefront of its development, and it is getting taken over by humanists. And that is very, very sad. And really and truly, I go back to that. If we cannot minister to people who are on the edge of hell, then I wonder what our conception of hell really is. Yes. And you know, those are important challenges for all of us. Amen. And also, just a note, I just happened to comment to Dick Bransford. I think that you know, all medicine is palliative. There's nothing curative that's going to give you anything except death at the end of your life, unless one, Jesus comes in the interim, or two, you are reborn into a life where we're not going to die. And outside that, all medicine is but patching until we die. And so we're all really in the palliative care business in some way or other, even though that some of us as physicians may not like to admit it. World Health Organization definition of palliative care, 2002. It's an approach that improves the quality of life of patients and their families, facing the problem associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Palliative care is really whole person medicine, and that's whole with a W, not H-O-L-S. And as an add-on to that definition, in palliative care for children, which we're interested in, it provides relief from pain and other distressing symptoms, affirms life and regards dying as a normal process, intends neither to hasten or postpone death, integrates the psychological and spiritual aspects of palliative care, of patient care, offers a support system to help patients live as actively as possible until death. We're very careful by telling people that come into a palliative care unit or a hospice, you have not come here primarily to die. You're here for us to help you live as well as possible until you do die, and none of us know when that is. And we get surprises. We're getting pretty good at doing prognosis because in our palliative care unit, the average length of stay is 18 days. And because of lack of resources, we've set a time frame of prognosis of 2 to 3 months, so we're trying to judge that. We get it right a lot of the time, but every now and again we have somebody come in who is almost unconscious or has a PPS of 10, as you'd say in palliative care circles, and the next thing they waken up and they live for 6 months or a year. And we've had a young woman survive for a year on 100% oxygen, which was absolutely unheard of before she came to us, at least by us. And maybe others have had situations like that. We use a team approach to address the needs of patients and their families. And we also follow up afterwards with families. We enhance the quality of life and positively influence the course of illness. And for a Christian to have the opportunity to witness to someone can tremendously influence their life for all of eternity. It is applicable early in the course of the illness, and I have a slide about that now, and I'll talk about that in a minute. So the question is, when does palliative care begin? I sort of mentioned about that, but in the old model of disease, and really until Cicely Saunders, most of life was spent, from a medical perspective, in therapies to attempt to modify disease. End-of-life care came roughly in the last 6 months, and bereavement care came after that. But now, in a simultaneous model of care, which is what we prefer to look at it at present, is that while there are therapies to modify disease, and this is especially applicable to someone with some cancers, especially breast cancer, where in spite of advanced disease, they may live for 9 or 10 years. And so combined with therapies to modify disease, there are therapies to relieve suffering and improve quality of life. Everyone who comes to the cancer clinic in most major centers in North America will have access to a palliative care physician at that clinic during the spectrum of their disease. And then there's the end-of-life part and the bereavement care afterwards. Now, do you want me to keep going, or any questions at the end?
Either way.
Yeah, I mean, if anybody wants to butt in and ask a question, forget. Now, I'm just going to, I put a slide up here that says forgotten disease, cancer, and I put that up here for this presentation because while it is not a forgotten disease in terms of North America or in Europe, in fact, every time you turn around, there's a fundraiser for cancer somewhere, or there's a run, or there's a biking, or there's something, and it's for either breast cancer, prostate cancer. In Canada, people grow beards for prostate cancer to fundraise. People race and run and bike and do all kinds of things for breast cancer. And but you know, when it comes to medical missions in the third world, cancer has been right off the agenda. And yet, that should not be the case. So 40% of all cancer deaths can be prevented. And cancer killed 7.8 million people in 2005, 3/4 of whom were in low and middle income countries. That's a lot of people. You know, we don't need necessarily advanced equipment to be able to provide reasonable palliative care. And so, if we have the knowledge to do it. In sub-Saharan Africa, 95% of all cancer patients present with advanced stage neoplasia, and the incidence mortality is really 1. Every one of them are going to die from it. So, I don't want to pass by without mentioning AIDS, and to say that I've got a slide which here, which I'll not go over in depth, and that is the number of deaths from AIDS in the last statistics I could actually get for 2009. So there are close to 1 million people dying in the top 12 countries with AIDS in Africa each year. That's a lot of people. And Dr. Faith Mwangi Paul, a palliative care director in Kenya, uses the bucket list film, which many of you may have seen, some of you may not, as to 2 guys and what they wanted to do just before they were going to, believing they were going to die, and they figured out these things they'd like to do. Well, bucket lists in Canada and in the States are very different from those in Africa. Yes. And the bucket list in Africa and a lot of countries in the third world, will you have enough to eat? Will you be able to get any treatment if you had cancer? Will you be able to afford any of the drugs? Will the drugs, in fact, be available even if you could afford them? And those are issues that are crucial and need to be attended to in the future. In 1993, I had, for the first time in my life, an opportunity to sit and do nothing for a couple of months, basically because I couldn't do anything. And I got to read more things than I had read in a long time, because that was how I got through my day. And there isn't enough baseball on in the mornings and the afternoons to keep me occupied. And so I read in the Toronto Star an article by Ian Gentles, one of the writers, who was talking about his father who died, and said to his surprise, he found himself encircled by the love of people who cared deeply enough for him, were confident enough to suppress his pain, make him feel that he was the center of their attention, and ease his passage out of this life. He died in peace with dignity. I usually rant at medical residents and everybody who I can. I do not believe in good deaths, which is a common phrase in palliative care circles. There is no death good, because death is the enemy. And in fact, in that even though someone dies peaceably and relatively comfortably, the suffering and pain that's left behind in the relatives and families is huge. And so there are no good deaths. And there have been a number of initiatives in Africa in regard to development of palliative care, and things have come a long way in a number of countries. World Health Organization has had joint palliative care and AIDS initiatives. The Diana Prince of Wales Memorial Fund has been helping with the development of palliative care in Ethiopia, Kenya, Malawi, Rwanda, and some other countries. And the foundation in the U.S. Has a series of twinning projects, the Foundation for Hospices in Sub-Saharan Africa, and they are still open to twinning projects with palliative care organizations in first world countries. And then there's the Open Society Institute for South Africa. Barriers to opioid use. The first one is legislation. Punitive law has made the drug distributors and pharmacists shy away from stocking these drugs for fear of violation of the law. Secondly, inadequate knowledge on the use of opioids amongst healthcare professionals, and fear of addiction to users influence healthcare professionals not to prescribe these drugs. This is not a third world problem. This is a problem in this country, in Canada, in the UK. There are still lots of physicians who are very hesitant about using opioids appropriately.
Ivan, would you say that is it more pronounced in Africa in opposition to opioids? That was my understanding.
Absolutely, because once we've introduced in most academic centers in North America and in the UK, students now get at least some training in palliative medicine and in pain management, which they never had up until 25 years ago in most places. And so there's been a tremendous advance in that.
Yes.
But this is still a huge problem out there. I mean, and I face this in every couple of weeks. I face a referral from a doctor who's hesitant to use opioids. I'll mention a case later. Accessible therapy in third world countries is rather an oxymoron because it usually is not accessible. In terms of opioids, 29 countries reported no opioid use in 2002. Many reported problems of availability. Many countries with oral morphine only. There are notable exceptions, such as Uganda, and morphine for cancer and AIDS is provided free by the government there. I have a chart here that's on the next slide, and it shows availability in Africa of opioids. And the red, which you can't see, but you can look at see on the web, is that is rarely or never, and in Kenya it is extremely limited, even in a country like that. And you will see that the number of countries where opioids are always available is extremely limited, and rather surprising. Tunisia is one of them, Mauritius, Morocco, Ghana, and Cote d'Ivoire. And what surprises me is there has been a great hesitancy in Muslim countries, especially, to the use of opioids. However, that's changing. Every year for the last 5 or 6 years, we've had a fellow from Saudi Arabia come to Kingston and do a fellowship year in training. They're setting up programs. The drugs are available, and things are changing dramatically in some countries. But in others, there is still tremendous ignorance. I have a picture here of a man that I visited in his home about a week after he came to Kajabi Hospital, which is a very well-resourced hospital in terms of Africa. And he had head and neck cancer. And if you see this picture, you can see that he's absolutely in agony. We had given him a prescription a week before for oral morphine. And the only kind that's available was oral powder that was mixed in with thyme or something like that. He went away with the prescription. Unfortunately, we find out he didn't have the money to fill it. He went home without it and suffered for a week in tremendous pain. And for those of you who have experienced people with head and neck cancers, you often can get tremendous involvement of nerves in the neck, pain in enclosed spaces such as the sinuses, and these people can die in agony if they do not receive adequate pain management. This poor man's wife was out working to try and get money, and she was out working selling herself as a prostitute. We did what we could to help her. One of the places that Dick Bransford and I always liked to go to was Lamu, and we were down there, and a young lady, a Muslim lady, came to me and she said, would you come to see my mother? And I said, yes. So she took me down the street. Half the time she covered her face, the other time, half the time she took it off and talked away to me. We went down to see her mother. Her mother had a gynae cancer. I'm not certain where it originated, but she was in a lot of problems. She had a lot of pain radiating down her sciatic nerve, probably from metastases involving the sciatic nerve, and which is not uncommon in pelvic tumors. And she had excruciating pain. Her daughter, a nurse, had searched the web. She'd done everything to get medicine. She treated her with amitriptyline, which is clearly easily available, and which is still the number one drug as an adjunct for the management of neuropathic pain, because the number to treat is far smaller than any of these modern expensive drugs that some of us are using in other countries, such as gabapentin and pregabalin and so on. So she had done everything. There was absolutely no opioids available in Lamu. And so I asked Dick how we did it. We got a bottle full of morphine, put it in a parcel, and sent it to her by plane. And apparently she actually died quite peaceably. But you know, the wonderful opportunity was to go into that house. And when I asked the daughter, I said, would your mother mind if I prayed for her? And she said, oh, no, she'd love you to pray. And I said, would you mind if I prayed in the name of Jesus? Not at all. And so we sat and prayed together in the name of the Lord Jesus. And you know, I'm one of these people who've always been critical of, I come from a group originally called Brethren, where people get up to pray and preach the sermon, really. And but I sort of preached a sermon in my prayer that day, and I thought of all the times I'd criticized somebody or had a critical spirit about people doing it. And, you know, these are the opportunities that exist for people who are dying and people. So what are the main symptoms of advanced cancer? Well, 89% of people have pain, but not everybody. And about 10% of people with cancer will die without pain. Weight loss, of course. Anorexia, difficult symptom for people to deal with, especially the caregivers, and especially wives, because you lose your appetite and you just can't eat. And there's a tremendous pressure from family to eat when you don't feel like it. You know, the common things are there, but dyspnea, severe. One of the most difficult problems for me to treat, in fact, is intractable nausea, especially in gynae tumors, and which I think is partly mediated by maybe the secretion of hormones. But one of the other things that people have difficulty understanding is the business of fatigue. If you have never been in a situation where you were so exhausted you couldn't lift your arm off the bed, then you have no sympathy or no understanding of what people have to go through often with end-stage cancer. And families can understand that if their loved one complains of pain, they can understand they're short of breath. They can't understand profound fatigue, and they'll try and push them to get up and walk when they really can't walk. They get frustrated, and a lot of it is corrected just with a little amount of education. But it's being aware of those things, knowing how the families are impacted by these symptoms, and being able to speak into those that are important. The business of drug addiction, I will mention it once or twice. I've probably got this slide out of place. It is a chronic relapsing disorder. If you get to the stage in your life and you're older and you're not addicted to something, you're never going to get addicted to something, or highly unlikely. And unless your doctor insists on giving you oxycodone, which is an absolutely potent addictive drug, and probably, it used to be one of our favorite drugs because it's got, it's fairly clean in terms of breakdown products, unlike morphine and hydromorphone. However, it is so addictive that we are trying to stay away from it, and it's also, it's probably one of the most popular street drugs in North America at this time.
That's OxyContin.
Yes, OxyContin. Yes, and the drug companies are doing everything they can to make it more difficult for those drug seeking. But anyway, you know, one of the problems is the solution is not to stop prescribing opioids. People die every day in car crashes. It doesn't stop us from driving a car or teaching our kids to drive. Personality, psychiatric disorders, genetic factors, male, adolescent, and social disadvantage are some of the issues which may make this worse. In terms of treating pain, the mantra of palliative care is, in terms of pain management, by the mouth, by the clock, and by the ladder. And the next slide is the ladder. It's the World Health Organization analgesic ladder. The next slide. And at the bottom, the non-opioids such as acetaminophen or Panadol and paracetamol if you're in other countries, and plus the adjuncts, NSAIDs, and some of the other adjuncts, which we won't really get to touch on today, especially for neuropathic pain. And it is always, in my opinion, important. If you are dealing with someone with neuropathic pain, you start with a neuropathic pain adjunct from the word go. The necessity of opioids will be decreased markedly if you do that, and in fact, may not be necessary at all. If the pain persists or increases, a weak opioid is in the latter, or a non-opioid. I'm not going to spend really much time on this, except to say that many people's choice for a weak opioid, and I just need to sip of something. And being Irish, don't assume that what I sip is any different than what you do. Anyway, weak opioids, most people's favorite drug is codeine. It's a totally useless drug in my opinion. First of all, codeine does not treat pain. It gets converted in your body to morphine. It is a prodrug. And therefore, everybody who gets codeine, who receives pain relief, if it's not, it's due to morphine that's actually treating the pain. There are about 10% of people in the world who cannot convert codeine to morphine, and you can feed them codeine from this to doomsday, and all they'll do is get totally constipated and sick, and they'll get no benefit of pain relief. So, if you look at the equivalent doses of, for instance, morphine and codeine, if you give 1 milligram of morphine, that's about the same as 15 milligrams of codeine. You know it gets absorbed 99.99% of the time. You know it works. You don't have to worry about... and so, if you want to start off nowadays, in most situations that I'm involved with, I never use codeine. If I was in general practice, maybe I might use it a little bit, but certainly in the palliative environment and in the elderly, I do not use codeine. I would use, in this country, hydromorphone. It is a little bit better in terms of profile than morphine in terms of problems with renal failure. And as you know, I assume everybody over the age of 80 has renal failure, moderate renal failure.
True.
Right? If you don't believe that, do the calculation, and you will find that they have all got it, or almost all. So assume everybody has renal failure to a degree. And so that's an issue with lots of drugs we prescribe, including opioids, and therefore it really needs care. Pain persists or increases, then into what's called a strong opioid, and the most common ones, morphine, hydromorphone, methadone, which has become a much more popular drug in the last 10 years. In the UK, it became very popular because they lost one of their drugs, and one of the things that we do that I won't get a chance to talk about today is how do you deal with the side effects of opioids when people get toxic. I will briefly say this: you can do one of two things if they're toxic. They get toxic from the breakdown products, which is morphine 3 and 6-glucuronide, and there's two other things you can do. You decrease the dose, or you rotate the opioid to a different opioid, and you attempt, if they're drinking well, you do nothing. If they're not drinking well, you try to flush it out with a bit of fluid. We use hypodermic lysis in palliative care, so we rarely use IVs because you can put the needle under the skin. You don't need to worry. It's got pulled out. The worst that can happen is you get water in your eye, or you get you can get families to just stop it afterwards. There's no bleeding.
Do you like Dilaudid in terms of renal failure?
I do, except the evidence is not as strong as we have tried to suggest for the last 10 years.
Oh, okay.
Yeah, so because you basically have the same breakdown products with hydromorphone, except it's hydromorphone-free glucuronide. And when you get a buildup of them, you still get toxic. It doesn't appear to occur as quickly with morphine. The best drug in renal failure is probably fentanyl. The problem with fentanyl is that never ever start a person on a fentanyl patch. People are going to lose their licenses for doing that because you will kill somebody if you start with a fentanyl patch if you keep doing it often enough. Because the lowest patch is too high a dose as a starting dose for an opioid. That's extremely important. The other route that's available, of course, is subcutaneous or intravenous, and we use those quite frequently, usually subcutaneously. As you know, fentanyl has a very short half-life, and therefore we prefer to give it subcutaneously and by a pump, and so that it's continuous infusion. So, and I apologize for jumping a bit here, but just as I come to these things, I think I'm trying to shove as much into this as I can. And opioids are the main treatment for pain. The actual incidence of addiction to opioids is less than 1%. The second thing, which is extremely important to remember, is that there is no respiratory depression if the dose is titrated to the level of pain. In case I don't get it, I run out of time. The second biggest problem symptom in palliative care is dyspnea. The number one, and let me say, I'm assuming that all inhalers and other oral drugs have been tried, and dyspnea is still a major issue, and there's no ability to reverse the disease process. The number one drug for the management of dyspnea, and you remember dyspnea is not tachypnea, so respiratory rate is not what we're trying to treat. We're trying to treat dyspnea, which is the sensation of not being able to get air, and they're not the same thing. And dyspnea is not treated until the respiratory rate gets down. You treat it until the symptom has gone. And the number one drug is an opioid. The number two drug is an opioid. The number three drug is an opioid. The number four drug is a phenothiazine. And the number five drug, if you use it, would be a benzodiazepine. So first opioids, second phenothiazines, and thirdly benzos. And the other thing is, in palliative care, I've spent half my life teaching medical residents with the elderly never to use a benzodiazepine. When it comes to palliative care, that is not correct. If somebody is lying in bed and they've got dyspnea and anxiety, you should not be afraid to use it. If they can't get out of the bed, they're not going to fall. Look, they're going to get confused possibly with all the drugs we use. So, and the other thing is to remember that every single drug we use causes some kind of side effects, and you have to be alert for the issues involved with that. I've sort of jumped ahead. Pharmacokinetic goals. Can we just keep moving to keep going? Keep going. Okay. Yeah. Pharmacokinetic goals. If you give opioids by the clock, you will use less opioids in a 24-hour period than if you use them PRN. So it's very important, by the mouth, by the ladder, by the clock. And so we give morphine and hydromorphone are given every 4 hours. The breakthrough dose is given every 2 hours. And you will also have less side effects in terms of pain and mental clouding, or less symptoms in terms of pain or mental clouding if you use opioids regularly. Now, I often prescribe an opioid while awake. So if a person is in relatively low doses and I'm giving them a 4-hourly dose. I will sometimes write it while awake so that the nurse doesn't wake them up in the middle of the night, or their family doesn't. If they're asleep, they're not suffering. So, but if they waken, they're encouraged to take their drug. The other thing is that educating people to use adequate breakthrough doses, and then every day we reassess the patient, or we encourage the patient to assess if they're requiring more than 2 or 3 breakthroughs in 24 hours, you need to up the regular dose. That is extremely important. The other thing is, I see people, and especially medical residents, and what they'll do is they'll say, well, we'll wait for 2 or 3 days and see how many breakthroughs they use. If the half-life is such, if it's not going to work in the first day, it's not going to work in the second day. So waiting, there's one exception for that. In methadone, which no one should use unless they've received adequate training and mentoring in the use of the drug, because of its long half-life, it does not reach a steady state until 7 to 10 days. And so it's a drug that requires a lot more care and use. Although, to my mind, it's a wonderful drug. It's reported to have NMDA activity, which means it's useful in neuropathic pain. It's also very, very cheap. It costs a cent for methadone, even in this country. If you go and so it's become more popular. It's also a drug that's less attractive on the street. And so it is very useful. It's a synthetic opioid, but it's a very useful drug to learn to use. It's also a good drug to rotate to. And for a while, in many cases, and in neuropathic pain, I've been using it as my first-line drug. Not everyone does that, but I felt that the arguments for doing that. One of the pharmacokinetic goals, to optimize drug therapy for individual patients, increase the probability of the desired effect, reduce the toxicity without compromising efficacy, and increase efficacy without unacceptable toxicity. Let me tell you, the first place I went to learn about palliative care was in Christopher's Hospice, and the guy got up, gave a lecture, and he says, the hand that writes the prescription for an opioid must also write a prescription for constipation. Everyone, and it's no good giving Colace or one of these stool softeners. They need a stimulant laxative, and they should be given that, because the big problem with opioids is constipation, and also people are afraid of getting nauseated, because the first time they experienced it, they went to emergency with some kind of trauma, and they had what I would call orthopedic doses, or maybe veterinarian doses of opioids, and they vomited within half an hour. That is not common with people who are given appropriate dosing. You know, I'm running out of time. I'm going to come to the end. I have some resources. I'm going to leave them with Lance. There is a website that is called Palliative Care Toolkit. It was actually written by 3 people, one of whom is a lady called Levi, who was a missionary in Malawi, along with her husband. And she's now back in the UK. But there is an excellent toolkit available. And there are some other resources in the web. And of course, I'm very happy to let you have my email address and to direct you to other resources if necessary. I'm going to get to the end. What's the take-home message? Understanding the relationship between pain and drug control policy in many countries. They need work. Christians need to be active and advocates. The role of international and national law and organizations. What are the barriers to opioid use? World Health Guidelines to evaluate national opioid control policy. And all of us in summary, are in a position to help make palliative care accessible and safe. Thank you.
Thank you.
God bless you. And I'm open to any questions that you may put to me, and I apologize for rattling through this. I normally don't go so fast, and I probably just flooded you with information.
That was great, Dr. Stewart. That was fantastic. So one thing I was just going to mention, and maybe just to ask your comments on, having done some palliative care in hospice myself. First, I'll comment. I'm elated. I think that historically, I think there's been some stigma associated with, I call it the H word, hospice.
Yes.
But I think palliative care has maybe permitted people to kind of let their guards down a little bit, and it's been more embraced. It's sometimes, palliative care, I think, is not just, in some ways you can think of it as a stepping stone to hospice, but it's truly, palliative care is very appropriate to people with chronic conditions.
Absolutely.
And you can receive palliative care for years. I've been involved in that, because a lot of people think once you start initiating palliative care and or hospice that we're going to hasten demise, and that's not our goal at all. The goal is to improve quality of life with a chronic condition, and that's what palliative care is. And in hospice, I think, is to help them in the dying process. But I don't know, what's your comments about the stigma associated with it?
Well, I've got a friend whose doctor lives on the street, and he said, if Ivan Stewart comes to your door, you know you're in trouble, and he's the last person you want to see there. So, but let me just give you an example of, your comment's excellent. Palliative medicine is a subspecialty of medicine. In the UK, that is an internal medicine subspecialty. In Canada, at the moment, it's a one-year fellowship. It's going to become a subspecialty of internal medicine in the next year or two. And so hospice are places go to die. Palliative medicine is what we practice with people, as you said, Lance, with chronic conditions. Let me tell you an example of that. 15 years ago, I got referred a patient by cardiology, intractable angina. The patient was on everything, had every procedure and drug known to the cardiologist, and he was continuing to have angina. And I didn't know what to do, so I put him on opioids, because what do palliative care physicians do? So he got hydromorphone. He ended up in a pump. This man lived for 13 years with a pump. During that time, there were a few issues. One was that he phoned up one day and he said, "Doctor, it's not working." So I said, "What are you doing?" He says, "I'm wallpapering." I said, "Well, get down off the ladder and stop wallpapering, because I can't treat you enough to do that." And he did require going to an intravenous route for a while, got an infection in his PICC line, had to go back to sub-Q, but lived 13 years. At the minute, I have a man. He's 5 years, intractable angina. He gets angina almost every day. He's on a subcutaneous infusion of 50 milligrams per hour of hydromorphone. That is a truckload of codeine. And he's been doing that. There are times when we've been able to decrease to 35 milligrams an hour, and there are times when it has gone up to 60. When he gets to 60 an hour, he tends to get a bit toxic. And so I'm probably convinced that when he gets angina, he presses the button, he gets pain relief, the catecholamine cascade doesn't get going and increases heart rate and all the other things, and it's actually prolonging his life. And when we worry about giving 5 or 10 milligrams of hydromorphone, here's a guy getting 50 milligrams subcutaneously an hour. That's the equivalent of 100 milligrams orally every hour of the day. That's what's possible when you titrate opioids appropriately.
Yeah, some of those patients, they have an incredible tolerance that have been utilizing it for years, and I mean, it would like, put us 6 feet under, but they're very tolerant.
The whole room. I mean,
and,
he's enough opioid in his cassette to wipe us out here. So
yeah, that's right. Yeah, but any other comments before we adjourn?
I'm just wondering, is there any, we talk about a lot of medication interventions with palliative care and in developing countries with maybe less access to certain drugs, less access to maybe, pumps and different things like that. Is there other kind of interventions that you would recommend in developing countries for children, or things that are helpful, even if it's not like opioids? Or
well, using adjuncts for pain relief. If you're talking about pain, you can use adjuncts, you can use opioids, but you've got to use something. The only alternative in cancer patients is to use palliative radiation. Now, I'm an advocate, when I get the chance, which is not very often, of advocating the development of palliative radiation as an alternative in places where drugs are not available, because you can get a lot of relief, especially in breast cancer, prostate cancer, patients with superficial cancer, so and single shot. The other thing is skeletal disease, where you get cancer in bones. And just as a quick reminder, the cancers that go to bone are paired organs: thyroid, breast, lung, adrenals, kidneys, ovaries, and prostate, because prostate and thyroid are paired organs, right? Ears. So those are the places to go to bone. Single dose radiation for bone mass is superb, right? The other thing is adequate use of steroids. People in palliative care, especially me, love steroids, right? If I'm stuck, I give steroids, right? Because they work tremendously well in bone pain. They can work in pain due to pressure, decreasing the pressure. Of course, there's number one line drug and brain tumors that are untreatable. And so those are the options. But if you're asking me what, caring and compassion certainly help. But if you're asking me if some of the therapies such as therapeutic touch and so on work, I'd say no. In fact, there is absolutely no evidence that these therapies have any effect. And to be advocated by people in palliative care. And look, I think when palliative care started, it was hold hands business, right? And now it's become, we're much more educated in terms of how to treat, how to manage, and we're fairly interventional. We run intrathecal pumps at home. We run epidurals, not infrequently in patients at home. We're learning how to treat this properly. And I come back to the issue. Managing people at the end of life properly and adequately and ethically does involve managing all the areas that trouble them. Pain, the business of terminal agitation, which many Christian doctors are afraid to consider managing, which is not uncommon because of the drugs we use. And so you can't practice palliative care really without access to decent access to these drugs.
Well, out of respect for time, I'm going to draw it to a close here, but I want to thank Dr. Stewart for this excellent presentation about palliative care. And I want to close with an advertisement for Bethany Kids. Please go to their website and check them out. They're doing fantastic work there at Kajabi Hospital, and I'm delighted for this program.